Good afternoon. We're going to go ahead and start, and Commissioner Burrell will join us when she arrives. My name is Robert Kincherf, and I am the current Senior Fellow in Law and Applied Neuroscience of a joint program between the Petrie Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. Better? Thank you. The Petrie Flom Center is a leading research program that addresses pressing policy, ethics, and legal issues in the area of healthcare and other domains. And we are pleased to be joined today by the Executive Director, Holly Fernandez-Lynch, who is with us at the back. We are also joined by Dr. Judith Edersheim of the Center for Law, Brain, and Behavior at Mass General Hospital. The mission of the CLBB is to understand the implication of rapidly evolving neurosciences for ethics, law, and public policy in a variety of different areas. Today's panel is one in a series that is put on by the Center for Law, Brain, and Behavior and the Petrie Flom Center. And we will be having another one at the end of this month that will focus on showing the documentary film Newtown, and then have a panel to think about the question, who helps the helpers once an immediate act or mass act of community violence is over, and we're sort of managing in with the after effects for individuals for that purpose. We've been joined by Commissioner Burrell. Do you want to take a moment and catch your breath, and Rita can go first, or are you ready to launch into the fray? Okay. And I would personally like to welcome Amanda Postolnik, who was the inaugural senior fellow for this joint fellowship in law and applied neuroscience. Professor Postolnik is a professor of law at the University of Maryland Carey School of Law, where she teaches criminal law, evidence, and law and neuroscience. And her current research work includes work on models of mind in criminal law and evidentiary issues presented by neuroscience. And so, without further ado, I'm going to have Amanda come up as moderator and get us really rolling. Thank you.
Thank you very much for being here, and in particular, thank you to our panelists. I'm going to introduce them briefly, because if I introduce them with all of their accomplishments, that would take up at least 3 times the amount of the full panel time. So we're very privileged to have with us today Commissioner Monica Burrell, who is the Commissioner of the Massachusetts Department of Public Health, and she is in charge of, among many other things, spearheading the state's response to the opioid crisis. Prior to becoming the state commissioner, she was the chief medical officer for Boston Healthcare for the Homeless, and as an inveterate underachiever, has served on the faculty of Harvard Medical School, Boston University Medical School, and Harvard School of Public Health, and received her MPH degree through the Commonwealth Fund Harvard University Fellowship. We will be hearing from Dr. Burrell first. Then it's our honor to hear from Dr. David Borsuk, who is one of the world's leading experts in how pain arises and what can be done about it. He's a professor of anesthesiology at Boston Children's Hospital. He's a core member of the faculty of the Center for Law, Brain, and Behavior at MGH, and the director of the Pain and Imaging Neuroscience Group at Boston Children's Hospital. He also was one of the first people, period, to use neuroimaging to look at what pain is and how the body creates and processes pain. And then we'll move back to policy with Rita Nieves, who is the deputy director of the Boston Public Health Commission, so we'll be getting state and city, and also holds a master's in public health and a degree in nursing, and is very much on the front lines of the opioid issues today. I'm going to give you some very brief framing, not to take time away from our panel. So you have heard that we have an opioid epidemic, and we do. We have an opioid epidemic because we have 2 epidemics. We have an overabundance of opioids cheaply available on the market, both legally and illegally, these opioid painkillers. And on the other hand, we have an epidemic of undertreated or untreated chronic pain being the single biggest medical problem in the United States in terms of both numbers of doctor's visits and associated health burden from loss of work, loss of quality of life. So how is it that we both have too many painkillers and too much pain, and neither is being solved? So we come here at the nexus of these two epidemics, and the genesis of the opioid epidemic is related to the epidemic in pain. So what's the role of opioids now? On a typical day in the US, 650,000 prescriptions for opioids are dispensed. 4,000 people initiate new use of opioids. 4,000 people initiate new non-medical use of opioids every day. About 600 people, by contrast, every day initiate heroin use. So you can see that the abuse of lawful opioids is multiples of the heroin problem. And approximately 90 people a day die in the US of an opioid overdose, approximately 33,000 deaths a year. That used to be almost entirely prescription opioids. It's increasingly street opioids and illegal fentanyl from China, but the prescription component is very well baked through. And this is a very unusual epidemic from a legal perspective because, on the one hand, it shares features with other drug epidemics that we're familiar with. Crack in the 80s, heroin in the 70s, where there's unlawful drug activity that's causing death, and there's primarily a criminal justice response. But it also shares a lot of features with tobacco-related health problems and tobacco litigations against manufacturers who have promoted products possibly being conscious that they pose an unreasonable risk. And because opioids are a lawful drug, class of drugs, and they can have an important role in pain treatment, we have opportunities for regulatory intervention and treatment that may not have been available in more conventional drug epidemics. And we'll hear from Dr. Borsuk on the medical aspects of this. So and I'll leave you with one thought on the manufacturers and how did we get to this place. There's a little town called Kermit, West Virginia. It's a town of population 400. So what's that, less than the 1L class at Harvard Law School? In 1 year, Purdue, the manufacturer of OxyContin, supplied the pharmacy there, the 400 people of Kermit, with 500,000 doses of OxyContin. So with that, I'd like to turn to Commissioner Burrell, who will tell us what the state is facing and what the state is doing about it.
Thank you. Good morning. Good morning. Where are we? It's afternoon now. Good afternoon, everyone. Great to be here with you today, and I really appreciate this chance to be with my esteemed fellow members on the panel. And Professor Postnick, thank you for setting it up so effectively. So as we talk today, I'm going to talk a little bit. There's so many different areas we can touch on, and really important the legal issues that you just raised. But I'm going to give you an overview of some of the work we're doing at the state level, and I want to emphasize the way that we're looking at this through a public health lens, and then we can open it up and talk a little bit to frame the issue for you. So some of you may know a little bit about the work we do at the Department of Public Health, and some of you may not. The Massachusetts Department of Public Health is the organization that really our mission from our start and our history has been to protect and promote the lives of all residents of Massachusetts. And that leads to a broad array of both regulatory responsibilities as well as promoting health, prevention, disease surveillance work. And the Massachusetts Department of Public Health has an extremely long history and was really the start of the American public health movement in the country, starting with a predecessor of both Rita and myself, Paul Revere, who was the first president of the Boston Board of Health back in the 1800s. So as we think about our broad work, one of the ways we work within the current opioid epidemic is that the state authority for opioid services, substance use services, the Bureau of Substance Abuse Services, sits in the Department of Public Health. So that becomes a primary role of us. As I think about the opioid epidemic, you heard a little bit about my past for 20 years in my clinical work, much of it which was at Boston Healthcare for the Homeless program. I worked with individuals suffering from substance use disorder and saw the ways in which the system worked and oftentimes didn't work for them. So I bring my clinical experience to a real desire to improve the way that individuals cared for with this medical disease interact with our system. And as I think about it as an opportunity to elevate the work of the Department of Public Health to what my goals for our department are, which is for us to be a national leader in innovative, outcomes-focused public health based on a data-driven approach with a focus on quality public health and healthcare services and an emphasis on the social determinants and eradication of health disparities. And when we look at it from this angle, I'll now put the information in the opioids in this view. So many of you have probably seen this information. As we work to make sure that information and data is more available, we now put out quarterly reports on what we have available related to opiate deaths in Massachusetts. So I show this to you to, I'll point out a couple of things. As you'll see, since the year 2000, there's been over a 450% increase in the number of opioid-related deaths in Massachusetts. And if you note from 2014 on, you'll see between 2013 and 2014 on, there's this steep rise in the number of deaths. And a really important contributor to that, you'll see on the bottom, is the now presence in our market of illicit fentanyl. And so fentanyl is really contributing to this vast increase in the number of deaths. And as you see, we're putting out more and more data. The areas in red there are areas that we're predicting, and we validated this tool to do predictive modeling for cases that aren't closed yet to know whether or not they will likely be related to opiates. And that's why we're able to put out this data more effectively. So as you can see, based on this information, Governor Baker listed addressing the opioid epidemic as one of our #1 public health issues. We break the data down in many different ways to try to really understand the root causes of this complex health and social issue so that we can address it appropriately. And I show you, I have multiple examples. I've chosen a few to show you. So if you look here, you'll see a map of Massachusetts. And this shows not only just the raw numbers of opioid overdose deaths, but the rates. And I point this out to you because when you look at rates, you'll see it's not just a problem anymore, opioid overdoses, of urban centers, as we've seen with, as you heard alluded to earlier, prior substance use epidemics. This is one that is, of course, the high numbers are in the cities, but it's really a problem throughout the state. And that's also another thing that's unique. So we have fentanyl in the picture right now, and we also have the incredible burden across the state. Look, for example, at the Berkshires or in the Cape area, which you may have heard. So it's really disseminated throughout the state, across socioeconomic lines. All communities are affected and impacted by this. As we think about this opioid epidemic and how to respond to it, I want to walk you through what we're doing at the state level. The governor put together an opioid working group 2 years ago when he first came to office. And having worked in this area for a long time, I can tell you that one of the most important things to me about this group was it was cross-sectoral. So it wasn't just medical individuals, it wasn't just public health individuals, it was people from the medical community, from public health, from criminal justice, from education, individuals suffering from chronic pain, as well as community members, people in recovery, so on. So we were looking at the current opioid epidemic from many different angles to see how we can approach it. And we came up with 65 recommendations and a 19-step action plan. I won't go through them all with you. They're available at the Department of Public Health's website, but I just want to give you a flavor of some of the things we're addressing that I thought might be of interest to you. First, in the area of prevention, I want to talk about prevention in two ways. So when you have a public health model, you have to talk about primary prevention, right? So there was this question about prescription painkillers, and we know that with this current opioid epidemic, more than ever before, individuals are beginning their substance use disorder with pain medicines. And whether it's theirs or something that they receive from someone else, that's a hallmark of this event, this epidemic that we're in. And we know from the data we've looked at that 80% of individuals who die from an opioid overdose, more than 80 really, started with a prescription painkiller. So that really changes the focus of how we look at primary prevention and how we educate around that. The other big issue that came out as we went and spoke to individuals across the state was the issue of stigma. And many of you have heard about stigma related to behavioral health issues, particularly mental health, but we were really seeing that stigma about what substance use disorders are and how individuals come into the state of addiction was extremely stigmatizing for individuals and their families and was keeping them from getting the care they needed. So we started this campaign. It's still going on. If you have a chance to join, #StateWithoutStigma. And it's really about getting people at the community level to understand substance use disorder for the medical disease that it is. You might hear a little bit more about that later, and how it needs to be treated as a medical disease, not as a moral decision or a choice. And part of this campaign includes, you'll see the 4 individuals up top are brave individuals who themselves are in recovery, who talk about their interactions with the system. And the #StateWithoutStigma is a social media campaign to try and educate individuals, primary education. The other area that we really wanted to focus on prevention is with the prescribers. So you heard a suggestion of that earlier. So how do we, as a prescriber myself, how do we make sure that prescribers have the tools that they need to, of course, be able to treat pain management when appropriate, but to balance that with the potential for opiate misuse? And I must say one of the most powerful groups that advocated to us and also to the governor was a group of medical students from all 4 medical schools in Massachusetts who came to us and said, we don't feel like we're trained enough and we get the education we need to be able to make those decisions between adequately treating pain and being able to diagnose opiate misuse, and we're not getting trained in that. So what we developed with the Massachusetts Medical Society and all 4 medical schools, the deans were primarily involved in this, and we led it through the Department of Public Health, and what we came up with is 10 core competencies that we all agreed on. We published it in Academic Medicine just recently, that we all agreed on would be taught to every medical student who graduates so that they have this education. You might hear about the pain-opioid balance a little bit later on today, but so that they start to have the tools that they need. We then went from medical schools to dental schools, to the nurse practitioner programs, the PA programs. The community health centers have all adopted these to make a uniform way that we educate. So over 8,500 individuals who graduate from Massachusetts programs as prescribers now get this education, and we are also expanding that to residents and people already in practice. So just to give you a flavor of the kinds of things we're talking about, we are expecting that individuals will get trained in how to evaluate pain, how to screen for a patient's risk of substance use disorder, how to understand both pharmacological and non-pharmacological options for pain management, as well as understanding substance use treatment options and being able to use evidence-based patient engagement and pain management opportunities. And then finally, to really address the stigma and the social determinants of health that surround individuals who are suffering from substance use disorder. So these core competencies are now taught throughout for all prescribers. In the area of intervention, I want to bring a couple of things to your attention. One is the new prescription monitoring program, which I hope many of you have heard of. It's a database of all prescriptions prescribed by prescribers not only in Massachusetts, but now we can access information from 28 different states, and it will soon be all of them. So the prescriber has, again, enhanced tools while they're sitting with a patient to add, in addition to the subjective complaint of pain, this other information that they can use as a tool when prescribing. Another intervention area is naloxone. So unlike other epidemics or, say, chronic alcoholism or crack cocaine, we have an immediate antidote that if someone is dying in front of you with an overdose, if you give them naloxone, it reverses that. So it's really, really important that we, all of us in communities wherever, so people ask me all the time, what's the one thing I could do? I would say make sure in your communities where you are that there's access to naloxone. Many people know it as one of the brand names, Narcan, so that when somebody is acutely overdosing and at risk of becoming one of those statistics, they can then get naloxone. We have 3 different programs for that in Massachusetts and have been a leader in developing those nationally. Maybe you've seen these. This is about Make the Right Call. It's really for individuals to understand our Good Samaritan laws, because what we found was individuals were helping somebody with naloxone, but they weren't staying with the individual. They were worried about their own legal ramifications because they either had something on them or they were with them. So this is an education tool about the Good Samaritan law. And then to close, in the area of treatment and recovery, I want to just tell you that part of the problem with our treatment system is we don't have enough access to beds, so we're increasing the access to beds. We've worked with the Division of Insurance to develop guidelines, because now it's mandatory to cover the first 14 days of treatment. We've also strengthened our own commitment to residential recovery by increasing the rates there. So all attempts to make sure that the full spectrum of care is available for individuals. And I hope you've heard of the STEP law that the governor signed last March, Substance Use Treatment, Education, and Prevention Law. This was really a first in the nation and has been followed by many other states, some of the prototypes of this. And just to point out a couple of pieces, there's always this balance of how much. I told you about the medical school intervention, which was all voluntary, the schools coming together voluntarily to put together and adopt these core competencies. And this is what we've done in the regulatory angle. So I hope, know there's a 7-day limit now on first-time opioids. Patients can do a voluntary non-opiate directive, just like you'd say, I don't want resuscitation or intubation. It's a similar concept. There must be now training done and screening in all schools, so looking at primary prevention and different ways to screen and pick up individuals. I told you about the naloxone, and then requiring evaluations in the ED. So this is all part of a program of trying to make sure that individuals, number one, understand the risks before they start using. If they're in their early stages, we pick them up with screenings early on. We make sure that prescribers understand the risks and benefits of opioid medications. It's really a relearning for us who have learned things through the 90s and such with the promotion of opiates for pain management. And then as part of that, putting the regulatory framework in to limit the amount. So just the sheer number of opiates out in the community is decreased. I'll end by telling you that all of this is done in a framework of precision public health, where precision public health is much like precision medicine, where you really target, in this case, a population, understand the risks, and then target your public health programming and resources to where they're most needed. And that's based on, again, understanding baseline data. So for the first time ever in Massachusetts, we're taking information from all of these different silos and bringing them together to help us answer questions. We've come up, again, on our website, you can find a lot of our results from this. I want to point out just a couple for you. One that I thought you'd be interested in. Again, for the first time, we've put together information we have at the Department of Public Health, birth, death rates, opioid use services, all at an aggregate level. And for the first time, put it together with DOC data. And this graph tells you all you need to know. If you're in practice, you kind of have a sense for this, but this is really proof to show that, shockingly, when somebody is released from a DOC facility, their risk of death from opioids is 56 times higher than the general population. So it's information, precision public health data like this that is helping us engage with our criminal justice colleagues in a very different way, because we have this information to back up our discussions and start to talk to them about how we can think about an individual before they're released so that we can have a smooth transition into the community. And then finally, as we look at our PMP, I just point your direction to the part in red. We now mandate use of the PMP, and we now mandate use of PMP every time someone prescribes opiates, and we mandate it the first time they prescribe benzodiazepines. And there's reasons and data behind this. For example, we found that if an individual patient has 3 or more providers or pharmacies, then their risk of death from a fatal overdose goes up 7-fold. So we want clinicians to have that information as part of their judgment when they're prescribing. And second, with benzodiazepines, if an individual is getting an opiate and a benzodiazepine, like say Valium, for example, their risk of death goes up 4-fold. So we're trying to use the data and the information we have to help us put out intelligent regulations and change health policy according to the data we have. And finally, I'll leave you with this. This is, if you get a chance to go to this website, this is a localization view of our data. So you can go to any town or city in Massachusetts and look over time what the opioid death rates have been and what the percentage of individuals using prescription drugs versus heroin, fentanyl, other illicit. So I leave you with that resource. And then I'll pass it back over. Thank you.
Thank you very much, State is making. We're going to hear now from Dr. Borsa. We will be taking questions and talking about some unifying things at the end.
So thanks for inviting me. I should probably request immunity before starting this, but the clinician is put in a very awkward position with all of this. And I hope the take-home message is the problem really is not having a national agenda to look at and get other drugs. There are hundreds of them on the pharmaceutical counters. The FDA sometimes doesn't pass laws to take on other medications that may be less problematic. And so the physician and the patient is in a quandary. And so I hope you take home 2 points, and one is the relative status of pain and addiction, and the second I've just mentioned, that there's really no good treatment for chronic pain, and I'll give you at least one slide to look at. And I think it's a bit of a cop-out to push some of our treatment processes into domains that have no therapeutic benefit in terms of trials. And of course, it may be better for the patient, but we're kidding ourselves that they're actually getting a treatment that may be helpful. So to me, the issue is this relative status is that if the Ebola virus was still going on, we would still be sweating it. More patients would be dying. It's much easier to understand a dead patient than a patient with chronic pain who has this silent process that is affecting them in a tremendous way, and sort of the suffering in silence. And if you look at what this country in particular, but also I suppose France and others, really did for the Ebola virus, was they took on a challenge and they solved it. And they got rid of it, and there's a new status. In pain, that has not been the case, for whatever reason. It can be political, it can be public policy, it can be pharmaceutical interests, it can be all sorts of things. But when you're sitting in a chair as a clinician, as I'm sure you guys have seen, and a patient comes to you and they're in chronic pain and they've tried 520 different treatments, not once, but maybe twice, you know, what are you going to do? And if you're a pain specialist, you may have a few more tricks up your sleeve, but the average clinician out there doesn't. And we had this seminar or series at NIH Consortium on Pain, and I happened to chair one of the sessions related to how do primary care physicians deal with this, and they really don't have any really good armamentarium. And just parenthetically related to your issue, I taught the Harvard pain course for a few years. It was 1 hour for the biggest and most dynamic or one of the biggest disease entities out there. So this has been pointed out that there is this addiction problem, and we know that there is a pain problem. And the numbers from the initial Institute of Medicine report were 100 million people in the country had chronic pain. And then a much, I think, more refined report out of NCCIH, National Institute of Health, was that 25 million or so had severe pain. So 25 million of us now and 25 million or more of us later have chronic pain, and it's a severe problem. So when you look at the total numbers of chronic pain, either 25 or 100 million, and its costs, now who knows how they work out these costs, and maybe someone can educate me on it, but the total cost to the US is $635 billion, as defined in the Institute of Medicine, and the opioid epidemic is around $78 million. a billion. And so it's very much harder to say pain is a big problem because it's silent and it doesn't hit you. It's similar to if I have a heart attack now, there's all sorts of bells and whistles, and an ambulance arrives and all that kind of thing. But if I have chronic heart failure, let him get on with it and find his own way. So when you look at the other domain in terms of suicide, and we've been lucky enough to write a paper on pain and suicide with Nora Volkart and I at NIDA, the suicide rates in chronic pain are very high. And we probably don't capture them well because it's Joe who walked along the river and jumped off the bridge because of it, or some other kind of thing. But if you look at the reported prevalence, 5 to 14% of even 25 million, if that's true, that's a real problem. And then if you look at the issues, and this is actually from down below here, is from this paper by Ilgen, it's from the VA, where I just wanted to make the point that things that you may not think are bad in pain-related domains like migraines, being up there in terms of suicide diseases or pain diseases. And so it's out there. And somehow we haven't captured this as a national issue of, let's deal with important things, including addiction. And Igor Elman and I had tried to put together this concept of, brain mechanisms go awry in both pain and addiction. And just to give you some practical examples, if I was a methadone addict and I received good treatment, and I'm off my methadone, and then you test me for my pain sensitivity years later, I'm much more sensitive to pain than anyone else. And so when I have surgery and I'm complaining that Dr. X is not giving me drugs, it's because your brain has changed. And conversely, pain comes out of nowhere. It is a silent brain matter at some level. So if I'm depressed and I have major depressive disorder, there's 62% of us will have a chronic generalized pain syndrome from nowhere, never having pain before, right? So our brains can be morphed into an altered state based on circuitry that exists. And of course, analgesics attack it, and opioids are well known to be part of the system, and when given for a long time, produce a problem. So I just wanted to give you, so you just end me whenever you're ready to end me. Yeah. So I just want to give you a couple of things on how we look at brain changes, because I want to give you an example of looking at the group of patients you mentioned, Joe or Jill getting a Percocet here at a party or whatever. So we can look at the brain both functionally, in terms of its chemistry, functionally meaning altered brain, and connections. And so when these actually get into a distressed or altered state, the telephone call from London to Washington no longer works. In other words, brain area A to B. When my brain is pushed for wanting and liking in a way that I can't help it, when there's certain parts of my brain where these connections disappear. And so what is shown here on this side is what we call resting state networks, which are low-frequency networks that can capture your brain state in health and disease, and it's been shown across many diseases to be altered. And then people talk about gray matter loss in various diseases, including chronic pain, and don't think about it as neuronal loss, but loss of a tree in the summer when there are lots of leaves and it's much more dense and volumetric, and a tree in the winter where it's gone. And so I'm giving you actual data, but just to show that it exists. But you don't have to look at the data. You just need to take the concepts away. So we took a bunch of very well looked at patients at McLean Hospital where they went through all their addiction profiles. None of them had a pre-opioid addiction profile. They were all what we called, and there must be a better term, of white-collared opioid addicts, in the sense that they all had jobs, they were all, et cetera. And there are three major brain changes that were observed in this. And one is gray matter volume loss in the amygdala, right? And this is a quantitative process. The second thing, so that happens in other parts of the brain. You can look at it in patients who come out after surgery and put on opioids. Their brains are changed in a similar way. The white matter tracts, these connections, are altered in these patients. And not only they're altered in a way where the white matter tracts shown in red here are much less robust. Those connections, again, between London and Washington are not working. And then lastly, in terms of function, and these are just data sets, but take the issue away, that the circuits for reward or wanting are, I want more is what the brain is saying in terms of how these brain systems are. They're much more sensitized to that. And so the clinician's dilemma are listed in points 1 through 4, and you can read them. And it's very difficult. And it's very difficult because it's hard to say, sorry, I don't have anything else for you. It's also hard to say that in the context of really knowing, well, opioids have worked for some. We don't really know that. The data's not out there. And, and so when you look at the Hippocratic Oath, and sort of a sentence out of it, a modern format of it is defined above. But I like this description about a patient's journey by Dr. Ling out on the West Coast, who's been one of the leaders in the field, because I think it's so hard to understand how people suffer. I mean, I had chronic pain on my left arm for a while, and I can tell you that it was as if the physicians I met did not speak English. There was a language communication problem in terms of trying to make this understood. And so at the bottom, this is where we are, as that frontline clinician of not knowing what to do. And here's part of the problem. These are most of the pain treatment modalities, at least from a pharmacological point of view. And at the top, you'll see NNT and NNH. Number needed to treat and number needed to harm. And if you look at the number needed to treat, they're not that different. But if you look at the tricyclics compared with the opioids, it's not such a big difference. And so this is an issue that needs to be taken into account. But at the end of the day, it's as if it doesn't matter what you throw at these patients, but there is data to suggest that opioids actually can make your pain worse. And the best example of it is in migraineurs, when if they put on opioids, they go into a chronic migraine state, and it probably is true for others. We really don't have data in the pain field. And it's not just the pain field, it's differentiating a pain brain, person versus a patient's brain who's preordained to the addiction domain. And we just don't have it. And so the drug data, I'm rushing through this because I'm being asked to move out of here. And so, there have been mitigation strategies. I just circle the one because although it looked like an interesting one to start with, in fact, there's data to show that this kind of approach is not very helpful. So, again, to the relative state, there is this issue of, the number of prescriptions, the actual problem in terms of number of prescriptions for chronic long-term opioid therapy and misuse are about the same. And so, what are the resolutions? Well, I think one of the resolutions is to lobby the government and pharmaceuticals to do something more dynamic. So basically, if we have an antibiotic for pain that has specificity and sensitivity, or an antibiotic equivalent, we wouldn't use opioids in the clinic. And to me, that somehow is not in much of the discussion. So thanks for your attention.
I want to ask one question before we get to the end, which is the commissioner mentioned the percentage of deaths and adverse incidents involving fentanyl. So you were talking about prescription opioids. Would you just speak for 1 minute on fentanyl?
So there is this problem of transition from one opioid to another. So for example, what has been called equivalent units for, say, morphine and methadone becomes very different if you've been on morphine and then take methadone. And so there are a couple of papers out in the methadone field of overdose with much lower doses of methadone in patients who had already been on another opioid, and they've died in hospitals, never mind on the street. And so when I saw your data, it sort of struck me that it's not the fentanyl dose that's normally equivalent. People are probably misreading it, and it may be an opportunity to educate addicts that, in fact, they don't need as much.
Thank you very much.
So we appreciate that some of you will need to do a hard stop at 1 to go to classes. We are going to continue with the Deputy Commissioner, and we do have some time after 1 o'clock for those of you who are able to stay to have a conversation with the panelists.
Deputy Commissioner Nieves will now talk to us about what Boston is doing and how Boston is partnering with public and private entities to address some of these issues.
Good afternoon, everybody. It's a pleasure to be here with you today. They're doing a great job with time management, so I better step it up and try to cover everything quickly. My name is Rita Nieves. I'm the Deputy Director at the Boston Public Health Commission, which is the City Health Department. And up until a year ago, I was in the role of Director of the Addictions Prevention, Treatment, and Recovery Support Services Bureau within the Boston Public Health Commission. Dr. Borsak asked me earlier if I liked my job, and I said, well, for the last 20 years, I've been working in addictions services, so I must like some of it, right? And in my new role, I get to more indirectly work with issues of addiction. But like I said, for the last 20 years, that's all I did. And today, I wanted to give you a quick overview of what we're doing locally and what we're seeing locally in the city of Boston when it comes to both prescription drugs and other and opioids. And quickly, the Recovery Services Bureau within the Boston Public Health Commission is one of 6 bureaus that we have. We have traditional functions of public health department, and we've run recovery services for more than 50, 60 years. So we've been in this business for a long time, and we've also been in the business of providing direct care. So not only do we do surveillance, we do prevention, but we've also been a direct provider of services. And so, this is the role of the Bureau to coordinate both substance abuse prevention, treatment, and recovery support services activities throughout the city. And we do this in collaboration with, obviously, the Department of Public Health, who's also the funder of many of the programs that and the services that we provide, both under prevention and treatment. These are some of the services that we provide, just so you have an idea. Our continuum includes, a site that is called PATH, providing access to addictions treatment, hope, and support, which functions as a treatment on demand site where anybody can come in and request to be placed in substance abuse treatment, or they can request information about how to get services. We run one of the oldest needle exchange sites in the state. The name is A-Hope, and the model changed a few years back. So we're also a site for overdose prevention and Narcan distribution in the city. And we also function as a drop-in center where people may come in. Everybody who comes to the program, for the most part, are active users. And when they're ready, and if they want services, we can also help them be placed into treatment. And then we have treatment and recovery support services. We have outpatients, 2 outpatient programs. We have a family residential for women and children. We have a transitional and stabilization support program. We also run a recovery program for men coming out of jail and prison that's called Wyman Reentry. And lastly, we have prevention and risk reduction services. We're one of the sites that DPH funds to do overdose prevention in the city, so we do trainings for active users, providers, family members, friends, anyone who wants to understand how to help someone who's having an overdose, and we also train them on how to use Narcan and distribute Narcan. We also have a mobile SHARPS team. This epidemic has brought a big issue with needles showing up everywhere. And when I say everywhere, I mean everywhere. So about 3 years ago, the mayor, Mayor Walsh, gave us new funding so we could start a team that their job is to go around the city and picking up needles. They pick up needles from needle kiosks that we have installed in different places in the city. And while they do that, they get to identify hotspots, places where we know active using is going on, and it allows the team to also connect with people who are on the streets and who are totally disconnected from any services. And so it's multi-purpose. And we recently added an outreach team that covers the Melnia-Cass and Mass Avenue area where, I'm sure you've read in the paper, we call it Recovery Road. Other people call it something else, and I won't mention the name because it's a very stigmatizing name. But it's an area with a high concentration of services, and where we end up moving our 2 shelters that came out of Long Island. And so the outreach team, walks the streets, engages people, responds to overdoses, distributes Narcan, and they do all kinds of tasks as they do that work. So just wanted to quickly share some Boston-specific data that, pretty much mirrors what's happening in the state. And these are, treatment admissions by drug type. The red line that you see at the top are other possible, they're prescription abuse drugs related admissions. When people come into a treatment, a licensed treatment program by DPH, they're asked the question, what is your primary drug of choice? And then they also ask them, what's your secondary, tertiary? So out of that information, we're able by city and by program to be able to determine who's coming into the programs and for what drugs, for what are their drugs of choices. So the point in this slide is, the red line, like I said, are other possible prescription abuse drugs. The blue one, and that may includes other opioids. The blue one, it's non-heroin opioids. And the point is that they're both going down, in Boston at least. I think the state is seeing something more or less, that mirrors that. And you'll see, as I continue to show you a few more slides, these are the prescription drugs overdose mortality data for Boston. And there are three periods here from 2007 to 2009, the blue color. 2010 to 2012 is the red, and 2013 to 2015, it's the green bar. And as you can see, it's going up. The prescription drugs overdose mortality has gone up in Boston in general from the 2010-2012 period to the 2013-2015. As you can see here, 7.8 to 15.5. By gender, also has gone up, both for females and males. As you can see, the male jumped from 10.5 to 21.6. And it's also gone up along race and ethnic groups. Now, this is prescription drug overdose mortality, but now these numbers, same colors, same grouping of same domains, gender, race, ethnicity, overall Boston. As you can see, without the fentanyl, there are, they seem somehow stable, especially among whites and males. And Boston actually went down from 7.1 to 6.8. So, and again, that's excluding fentanyl. Now look at what's happening when we look at fentanyl overdose mortality. It's gone up both in Boston dramatically, as you can see, from 0.7 to 8.7. And among whites, big jump, and among males, and also big jumps. So, the commissioner made reference to this. We're very concerned about the contributions that it's primarily illicit fentanyl that we suspect is really contributing to this increased mortality overall. And again, the amount of within the prescription drugs mortality, how much is we suspect fentanyl it's having an impact on. And this is very clear how you can see that the blue line is total prescription drug overdose mortality going up between 2013 to 2015, a big sharp increase. But then when you look at the green line, which is without fentanyl, just other prescription drugs, no fentanyl included, going down in the other direction. And then when you look at the red line in the last 2 years, that includes all the overdose deaths, that includes fentanyl, going in the other direction. So we are very concerned about this phenomenon to the point that we have been looking at the 2015 data for Boston and seeing some death among drug overdose death associated with stimulants now, with fentanyl in it. So starting to think about what should our conversation with our clients who are using stimulants should look like, and is there a role now to be distributing Narcan to people who are using cocaine, that are buying cocaine on the streets thinking that they're buying cocaine, and having both fatal and non-fatal overdoses because they're buying stuff that has fentanyl. And this is data from our EMS. EMS is part of our City Health Department agency, and this is what we're dealing with. We get weekly reports from EMS on their transports. NRIs are narcotic-related illnesses, and since 2010, you can see the blue line. That's the total amount of incidents that they report. Their transports that they're responding to that have to do with a narcotic-related issue. So, the red, are the times that they have to administer, also going up. The yellows are referred to the medical examiner. These are people that, when they respond, the person already is deceased for the most part. So, a couple of things that I wanted to mention. So, what we've been doing. There stuff we're doing around youth prevention, stuff we're doing around overdose prevention, Narcan administration, some environmental strategies, some partnerships with first responders, and also some work around expanding access to treatment. Among the youth prevention strategies we're using, we started to use a life skills training. It's an evidence-based curriculum for 9th graders. This is a partnership with Boston Public Schools. And it has two focuses. One, increasing the perception of harm related to prescription drug misuse among the students, and one focus around positive parenting materials that includes tools for parents to engage children in conversations about alcohol and drug use. We are in the process of doing a need assessment around substance abuse prevention strategies in the city. It's never been done, and we wanted to be able to do an assessment that we could look at, what's our baseline, and then help us plan very focused strategies around, how do we implement some strategies around prevention of prescription drugs among young people. We have done a ton of training around overdose prevention. Every week we train multiple individuals. These are some of the things that we cover, how to recognize an overdose, factors that increase risk for overdose, and how to refer people to recovery services. We have a video, that's our YouTube link. And we also are doing we have expanded training for multiple groups. You know, the commissioner mentioned people who are incarcerated come out and have a huge amount of risk if they start using again. So we do work with jail shelters, detoxes. We train mental health providers, medical providers. We're doing work with the business community and public places. We've done work with family and friends for a long time, and also working with public safety and law enforcement personnel. We have installed drug kiosks in 12 police stations, so we can, throughout the city, to encourage safe disposal of potential dangerous prescription drugs, and they're used very frequently by people. We have done some strategies to hopefully decrease deaths that we're seeing in public bathrooms throughout the city, and that's a campaign that we have implemented. Training business owners on how to minimize the opportunities for that to happen, and what to do, and how to train them on overdose prevention and Narcan use. And by now we have all first responders are carrying Narcan, which was a major accomplishment. It took years for us to accomplish that, both EMS, fire, and police. And we created this site so we could really have a low threshold site where people could just come in and ask for services whenever and however they wanted. And we linked it to 311, so now if anybody needs anything, they could just call 311 and we can refer them to PATH, and someone can help them get into treatment. These are some of the ongoing challenges, as you can see. So my time is up. Thank you.
Amanda, this is being recorded, so you can't be heard unless you're by microphone.
Okay.
So what I was going to suggest to folks, if our panelists would come up here, and we'll interact with folks in the audience who can stay for a bit. When you speak, because we're being recorded, you see the little black plastic boxes along the rim of the table. Just punch the button at the front as you speak, and the microphone will be able to pick you up. And Amanda, take it away.
Sir?
So this question for Dr. Borsuk. I understand the perspective of we don't adequately have mechanisms for treating chronic pain, but why is the prevalence of chronic pain so much higher in the U.S. than anywhere else, and rates of disability and things like that? Or at least the data seem to suggest that certainly prescriptions of opioids are, hundreds of times higher in the U.S. than they are elsewhere in the world.
So I think the first point is that the rates are actually equivalent in Western society in terms of chronic pain. I don't remember the tonnage of opioids imported to the U.S., but I know in the 90s it was like 100 tons or something compared with the UK, where there was 2 tons or something, or one, a minuscule amount. I think, and I went through this transition from no opioid use to using it. What happened was, opioids were used for cancer pain patients and end of life, and it made sense. And then this chronic pain process was part of new pain treatment processes at institutions. And opioids look good. And in fact, I think we were hoodwinked, and I was part of that group, that when you put someone on chronic pain on opioids initially, you may have a good response. And if you look at the Cochrane data for numbers needed to treat, the real problem and data that's come out, some of which I just flashed through, related to how long they're on it for and their dosing. And just to get a total dose out of everyone's mind, anyone in this room can be put on opioids up to 16 grams or more a day. That's not the problem. So it's just how you advance it. And that was a record for me for a cancer pain patient at Mass General. So the total dose theme is an interesting concept that hasn't been worked out. Because if you can give someone 1,000 milligrams a day and they're not an addict and they're pain-free, few people will argue with that if that works. As clinicians, we don't know that. And so it's like almost every drug we use, that's been through pharmaceutical controlled, randomized trials, the average response is 30%. And what's beginning to happen is that people are beginning to look at responders versus non-responders. So you can get for drug A group that respond almost 100% and a group that don't respond and someone in between. So how do I know you're a responder? And the same theme applies to the opioid process, where it may be that a certain percentage of the population make good clinical candidates. We don't know that.
This is a question for for Ms. Nieves. One of the challenges that sadly you didn't have time to go into, but is of great interest, is the challenges posed by persons with co-occurring mental health and substance use disorders. Can you say something about that and what the city is looking to do?
Big challenge for us, because I'll speak about what we know about females in particular. We implemented a study that was funded in 2000 by SAMHSA. It was called the co-occurring study for women. And we were looking at how to integrate both mental health, substance abuse, and trauma into substance abuse treatment for women. And we found in the study that lasted about 5 years that up to 80% of the women that were coming into treatment, both outpatient and residential, had a history of trauma and had some other co-occurring mental condition. And, sadly, when clients present to our programs, we have people here from one of our transitional programs in the Boston Public Health Commission that deal with pretty young individuals, many of them, also with co-occurring conditions, come in, and the system is not equipped to treat both of issues, at the same time, or clearly not under one roof. And people end up having to be referred to other providers in other systems of care. So that alone is the first barrier, because there are not that many places where you can send a person that is dealing with an addiction and also having a mental illness, and having someone who could treat the whole person in an efficient way. So there are lots of barriers to care for people with co-occurring conditions. And I think it's one of the reasons why we end up seeing a lot of clients leave treatment early, and then obviously being labeled as not being ready, not being compliant, and not being serious about their treatment, because their underlying condition is really they're experiencing lots of symptoms that treatment programs are not equipped to deal with, and as a result, again, people are labeled all kinds of in all kinds of ways, and there's also a lot of stigma. If you get to have somebody seen by a mental health provider and they're put in some psychotropic medication, there's a lot of stigma attached to why do you have to take all those 5 medications and bring them to treatment, and are you really benefiting from that as opposed to just trying to get high on something else? So it's a major issue, and I think the field is slowly beginning to recognize it, and also attempt to try to incorporate strategies to respond to the needs of the clients.
This question, you showed a lot of trends that basically looked at, I guess it was mortality rates, et cetera, by sex, by gender, and by race.
Mm-hmm.
You looked at Are you seeing similar trends? Is the problem bigger, smaller?
It's bigger among the 25 to 44 age group, but we have seen slight increases in younger people, which, you know, they used to not show up in you know, any significant way in our data. But you know, we have people between 18 and 24 that you know, are showing are you know, being really affected by this as well. And traditionally they were not so, you know, present in the data.
And then my follow-up question is really related to prevention in schools. Are you confident that what we're currently doing is effective? Or do you think there's an opportunity there to improve?
We are just getting started. I mean, the Boston Public Schools and that whole system, it's an area that we always wanted to have the opportunity to start working in a significant way. And with funding from the state, you know, we're beginning to implement those strategies. But that is such a prime location for us to be at and to really collaborate. We're actually hoping that we get some funding from GE to do some serious work there in the near future, but we're not doing nearly, you know, enough to get the kids, you know, early on, and then intervene with those that are already, you know, experimenting with both alcohol and other drugs.
Yeah, first I wanted to echo what you said about, you know, because at the Boston Public Health Commission Transitions Program, I wanted to echo what you said about the co-occurring disorders. We've seen it. I'm an intern, but I've seen it multiple times already in the short time I've been there, and it's been really, really difficult. So thank you for bringing that to light. My question is, Dr. Borsuk, I wanted to, and for Rita, I'm curious about the role that insurance comes into play as far as funding alternative treatment options. And my understanding of it is that alternative treatments are not accessible, especially when we're talking about people who have differing SES, socioeconomic status, and access to treatment as far as from a financial perspective. And so I'm curious what your thoughts are on that.
Well, my basic thought is whatever works should be given, you know, whether it's throwing you into the Charles River. But I think if you want to approach things from a mechanistic or outcome basis, there is a bit of a challenge. And some people, you know, seek alternative medicine, and it does well for them. In general, most of those processes are not cause no harm, so it's a safe place to be. But you raise a huge point that basically, unless you have insurance, you won't get it. And if you do have insurance, you may get it. And I think it's like everything else. If data comes through that is, you know, shows that things work, like CBT is actually one of the few psychological approaches where there's good data, and it's being applied, and we're seeing good results. So I think that's part of the issue. I must say, I see it at Children's trying to get referrals for psychologists to treat patients, and it's almost impossible to find psychologists, and I think a lot of it has to do with your underlying theme of if there's no money, there's no treatment, or there's no good treatment, or no easy opportunity in terms of access.
Just wanted to circle back to the topic of stigma and what you think are some suggestions that you could make about people in their everyday lives kind of working towards, you know, ending the stigma. From a student's perspective, we're planning a forum in May. We have a lot of interest in this topic, but I'm not sure that people really know the action steps that they can start taking.
I think, you know, starting from holding yourself accountable and your peers on how you talk about this issue and how you talk about people that are dealing with this issue. And, you know, words matter. And I mentioned before that we have lots of services in the Mass Avenue, Melnia Cass area, close to Boston Medical Center. And we had to start our own campaign against the people that were calling it, the methadone mile. And there was actually a business in that stretch that put a very nasty sign, in their window that, it was very stigmatizing and about the people that were walking in front of their business. So, starting with the words we're using to refer to people who are addicted, and starting from, your own circle, often most of the people that are in a group like this know somebody who's addicted to something, or it's, struggling. And we have a role in making sure that, we're respectful and that we show some compassion and some understanding about how people who happen to be struggling with an addiction, well, I've never met anybody who chose to be addicted to anything, I don't know if anybody has, but I never, met anybody who said, I want to be in this right now in the corner of Mass Avenue, Melnia Cass, asking for money, because I need a fix. And I think, language, looking at language and the narrative we're using, it's a good place to start. And it's a good place to start education and increasing awareness.
It's a little ironic that these patients can go to their doctor to get the prescription. They can't go to their doctor to get the treatment. Because for other drug-related public health problems, we've taken a moral/criminal approach rather than the public health approach that so many public health actors ask for. So this epidemic, in a way, may present an opportunity to say, well, these people became medically addicted. It's more consistent than to treat them in a medical narrative rather than the shame and morality narrative of salvation and sin. Ma'am?
Yes, my question has to do with the use of medical marijuana in terms of treating chronic pain, and as both for somebody who is already addicted perhaps, or somebody I know somebody who's approaching addiction in their course of cancer treatment because of the pain associated with it.
So numerous drug companies are looking at marijuana equivalents. And there's no question that cannabinoid receptors are all where pain receptors and the pain system is. There's no good data, but my sense is that it's a better deal than opioids. I've experienced the problem of, I don't know what to do, sir or madam, and they've said, well, I'm going to try marijuana, and obviously the laws in the state, the federal law proscribes most of us from prescribing. And so I think there is this issue of alternatives that are much less problematic. There have been a few papers in the field, especially from a group at Hopkins, where they've looked at very low dose of drugs that we would think are in the bad domain, the marijuanas, etc. And in fact, in their trials, at least as I recall them, the outcomes were better than antidepressants, etc., etc. So I think there is this theme brewing, both from NIH and from patient demand, that these alternatives are not bad. I think the other thing, just conceptually, if I have a brain or an addicted brain state, you're not going to change it, or you're unlikely to change it in a minute. I mean, there were these going under anesthesia, and we've seen it for pain patients who've not responded and go under ketamine anesthesia, for a week, and similarly for opioid addicts. And I think they are all thematic of rapid brain changes. So there have been a couple of reports of ECT, making pain brains better or individuals better. But I think you raise a good point. And, I'm not sure whether my thought is rational in this society, but there are all these drugs that don't make it because one or two patients had severe outcomes, and that's not good, of course, but it's a business decision and not a decision for the betterment of society. So the question really is can we push forward other therapies until they actually, which may be better than opioids and maybe many of the other drugs, and sort of put them out as orphan-type drugs, which the FDA actually has a format for. But something needs to give where, we're paying an enormous cost for lack of knowledge. We're paying an enormous cost for just letting opioids be out there and not knowing what to do with them, at least in the clinic, if you're treating pain. And thematically, what has happened is that if you come to a pain clinic now, at most pain clinics, certainly at academic institutions, may put you on opioids with your primary, and then they throw you back to your primary physician, who is probably the least adept at handling that problem, although they can now connect with the pain. So the best example is a colleague of mine who I help train is now at UC Davis, and he would say something like, I will help you manage this process, and they had a very good team effort. That doesn't happen everywhere, where there are experts working with primary clinicians on a day-to-day, patient-by-patient basis. And I think that's the unfortunate thing. So if I'm out in the middle of Nebraska, or wherever you want to call it, it's much harder. I think some of the data-driven processes that are beginning to occur in epidemiological studies and some of the scientific things are beginning to help coalesce towards a much more rational process. Because a lot of the stuff that's gone on recently, including the CDC recommendations and including the NIH recommendations, are not totally based, at least for pain, on a rational scientific basis. And I think it's a good start, and I'm sure 2 government officials will be here in a minute. But I think that's the problem. We really are ignorant. I mean, if you said, from an addiction point of view, just get rid of opioids in the clinic, would it stop the opioid addiction problem? No.
We have time for one more question. I know we could talk to these people all day, but I have to be respectful of their time and let them go at some point. In the back, Chrissy.
Excuse me. Hi. So I'm Chrissy. I'm the administrative director at the Petrie Flom Center. And I'd like to build on actually the last 2 questions. So talking about stigma, we talk a lot about stigma around addiction and mental health issues. And then Dr. Borsuk, you were just talking about how you feel like a lot of responses to pain aren't necessarily very rational or scientifically driven. I wonder how much the issue of stigma comes into play around chronic pain, and it gets cast. I'm thinking, for instance, of the fact that I know there's been discussion in the press about whether or not fibromyalgia is a real thing. So issues like that, I wonder how much, you made a very good case that chronic pain is very undertreated and underdiscussed, and I just wonder how much stigma might play into that.
Well, I'm reminded I was at the Deaconess training in neurology residency when the HIV process broke, and the stigma around that was enormous, and then science and marketing came together, and they're in a good place. Well, we're in a good place as society. I think one of the problems with pain is the following. Where is it where chronic pain gets stuck, right? So for patients, 60% you can treat them, they get better, they're functionally in a better place. But for a large group, it doesn't matter what you do. It's like taking epoxy glues and putting them together, and at some point you can swirl it around, and at some point it gets stuck. And that's part of the problem. The second part is, I don't see anything wrong with you. What's your problem? And then, I know a whole lot of migraine patients or whatever patients who are doing okay. So it's this sort of labeling of subgroups of patients. It's also this labeling of why aren't you at work, right? Well, I don't know if any of you have or have had chronic pain, but it's very difficult. And, you know, there are two themes that actually happened for me in my training, and I'm embarrassed to tell you about it, but I will anyway. One was the so-called battered woman, you know, syndrome, rape, and what have you, and how it leads to long-term effects. We're seeing it now in kids who have just chronic pain syndromes, and they may get better before their 20s, and then they have all sorts of problems later. So, you know, whether it's suicide or depression, I mean, it's well-documented stuff. So the changed brain syndrome is a problem. We've had kids who've got better, right? They have no pain, and you look at their brains, and they're not normal, right? So they are just waiting for their brains to be put on fire in some domain. This transition between anxiety, depression, and pain, they're very similar circuits. And so I think the stigma issue is huge. The pain community, by and large, has done a good job until this opioid epidemic. And I think it's hurt everyone because clinicians are scared, patients are also scared for the most part. And so the stigmatization of this it's changed the practice in pain clinics. They don't take responsibility for patients in terms of long-term treatments. And so it is a problem. I don't know if you wanted to add anything.
So on behalf of the Petrie Flom Center and the Center for Law, Brain, and Behavior, let's thank our panelists, and thank you for your interest. Thank you very much.